The Acumed locking clavicle plate system is an extensive collection of 31 plates designed to treat comminuted fractures, malunions, and non-unions. This includes a range of 16 low and narrow profile plates that specifically address the superior midshaft portion of the clavicle. Please refer to the product brochure for a complete description of the surgical technique and range of options available for radiographic evaluation. After completion of a thorough radiographic evaluation, the patient is placed in a beach chair position with the head rotated and tilted 5 degrees to 10 degrees away from the operative side. A bolster is placed between the shoulder blades and head, allowing the injured shoulder girdle to retract posteriorly. This will facilitate reduction by bringing the clavicle anterior to restore length and improve exposure. Surgeons may choose one of 2 incisions. Option 1, a 3 cm to 5 cm transverse infraclavicular incision, is made parallel to the long axis of the clavicle so that the scar does not lie over the plate. This approach provides convenient, unlimited access to the entire length of the bone. Option 2, an incision along the Langer's line, running perpendicular to the long axis, provides better cosmetic results and less damage to the supraclavicular cutaneous nerves. Attention is made to protect the cutaneous nerve branches as they cross over the operative field, although this may not always be possible. It is also important to keep soft tissue attachments to the butterfly fragments in an attempt to maintain vascularity. The fracture is cleared of hematoma and debris and anatomically reduced. Reduce the fracture by placing 2 reduction forceps on the medial and distal fragments. Distract, elevate, and rotate the distal fragment to obtain reduction. Once the appropriately sized left or right midshaft clavicle plate is selected, place the 2 middle compression slots over the fracture, ideally leaving 3 locking and/or non-locking holes, both medial and distal, to the fracture fragments. Usually, the larger plates are ideal for most males, medium plates for smaller males and most females, and the narrow profile plates for the smallest patients. In a fracture with marked comminution, the plate is used as a template to bring the clavicle out to length. Bringing the clavicle out to length decreases tension on the fixation and helps restore the normal function of the scapula and clavicle as they work in a unit with shoulder flexion. In fractures of the middle medial third, the plate is utilized as marked, medial and laterally. In fractures that involve the middle lateral third, frequently the plate may be rotated 180 degrees, or a plate of the opposite dexterity may be used to anatomically fit the curve of the clavicle. In cases of non-union or malunion, the curve of the plate may assist in anatomic reduction of the clavicle, reducing strain on the SC and AC joints. In this incidence, fibrous tissue is debrided and necrotic bone is excised to good bleeding bone. Autograft or allograft bone may need to be utilized to fill in the gap, and the necrotic fibrous tissue is excised. Prior to placement of the plate, lag screw fixation across the major fracture fragments may be performed for neutralization or axial compression. Once the plate's ideal positioning has been selected, it is provisionally stabilized to the clavicle with plate tacks or plate clamps. Ideally, the plate should be applied in compression mode. Take care to ensure that the intervening fragments are not stripped. Preservation of soft tissue attachments helps ensure that the length and rotation of the clavicle are correct. Non-locking screws may be placed either unicortical or bicortical. It is important not to overpenetrate the inferior cortex and potentially risk neurovascular injury. The clavicle retractor should be placed under the inferior surface of the clavicle to protect the neurovascular structures from overpenetration of the drill bit. Replace drill if it comes in contact with clavicle retractor. For early stability, the first 2 3.5 mm screws placed should be medial and lateral to the fracture site. Once 2 screws are installed, the plate tacks or bone clamps holding the plate to the clavicle may be removed. Tapping is recommended for patients with dense bone. Using the locking drill guide, place the 3.5 mm locking screws into the threaded holes so that there are at least 3 screws on each side of the fracture. The outermost medial and lateral holes are angled 10 degrees, and the locking drill guides must be inserted to account for these angles. When drilling and inserting for the most medial screws, remove the bump from the patient's head to extend the neck and allow easier access to drill and place the medial screws. Once the medial screws are placed, the bump is placed back underneath the patient's head to support the neck. An intraoperative radiograph is recommended to check the position of the screws and the final reduction of the fracture. After radiographic evaluation and thorough irrigation, the clavicle pectoral fascia is closed over the clavicle and the plate, followed by closure of the subcutaneous tissue and musculature in separate layers. Finally, close the skin by using interrupted absorbable sutures with a subcuticular stitch and dress the wound. The Acumed locking clavicle plate system includes a range of 5 plates for application on the anterior surface. In some instances, it may be more advantageous to place the plate on the anterior surface of the clavicle due to the fracture pattern. The application of the plate on the anterior surface of the clavicle allows for the insertion of longer screws, which potentially have greater pull-out strength, may reduce soft tissue irritation, and directs instruments away from the vital subclavian vessels.